Good morning. It's my pleasure to announce Katie Sackett, Dr. Katie Sackett, to give the grand rounds this morning. Katie has been a resident in our program. Thank you. Katie's been a resident in our program, and she, out of usual sync, did a transfusion fellowship with us. That was 2 years ago?
Yes.
And she began this research then, and it sort of went along, and so now she's going to give us the results of an analysis of post-transplant back type formation, comparing cord blood, peripheral blood, and bone marrow sources. Thank you.
Thank you. Okay. I have nothing to disclose. So my objectives this morning are going to be comparing the basics of different allogeneic stem cell transplant sources, defining back type and its importance in transplants, including ABO mismatch transplants, and then discussing the differences in back type formation between these three stem cell sources. Tens of thousands of hematopoietic stem cell transplants are performed each year to treat diseases including malignancy, metabolic disorders, or others resulting in bone marrow failure. There are many aspects that go into these stem cell transplants, so I'm going to be touching on just the tip of the iceberg. The most important is the extent of HLA matching. But then also one can consider the stem cell source. So hematopoietic stem cells can come from three different sources: cord blood, bone marrow, or peripheral blood. These stem cell sources can be either autologous, so from the patient, him or herself, or from an allogeneic donor. They also can be ABO matched or mismatched. And then patients can undergo variations of their chemotherapy regimen. They can experience myeloablative or non-myeloablative, and another term for non-myeloablative is reduced intensity. The decisions regarding these aspects are made keeping in mind the underlying disease that's being treated, as well as the treating hospital's preference, and characteristics specific to the patient, including the patient's age, any other comorbid conditions, and the disease that's being treated by the hematopoietic stem cell transplant. A very fair question to ask now is, how do these different factors affect outcomes? So first I'll be going into how the source of hematopoietic stem cell transplants affects outcomes, comparing bone marrow, peripheral blood, and cord blood. Then I'll be looking at ABO matched versus mismatched transplants, including the categories of ABO mismatched transplants, and then the different consequences of these mismatched transplants, and then I'll be talking about the retrospective analysis. In 2007, Takahashi and colleagues looked at the varying outcomes comparing the three different sources of hematopoietic stem cells: cord blood, bone marrow, and peripheral blood. And what they found was that umbilical cord blood stem cell transplants showed delayed neutrophil and platelet engraftment compared to bone marrow and peripheral blood sources. Also, hospitalizations are longer for those receiving umbilical cord blood transplants, likely related to the delayed engraftment of these two cell lines. However, umbilical cord blood recipients are able to decrease and even discontinue the dose of immunosuppression, as noted in this paper, by cyclosporin and methotrexate, because they have decreased incidences of GVHD compared to their counterparts of bone marrow and peripheral blood recipients. Finally, and most importantly, there was no difference in treatment-related mortality, relapse, and disease-free survival between all three sources. So now let's look at ABO matched versus mismatched hematopoietic stem cell transplants. Interestingly, although ABO blood group types should be compatible in solid organ transplants, hematopoietic stem cell transplants are performed across ABO blood group barriers. Here, as I noted earlier, HLA typing is the most important aspect. And HLA groups are inherited independently from ABO blood group antigens. Nina Worrell wrote this very interesting review article comparing the different types of ABO mismatched transplants. So the next couple slides I'm going to show are taken from her paper. ABO mismatched transplants are categorized into three different types: major, minor, and bidirectional. In a major ABO mismatched transplant, the recipient has preformed antibodies against antigens on donor cells. In a minor ABO mismatched transplant, the donor delivers preformed antibodies, B cell lymphocytes, and also plasma cells that can make antibodies against antigens on the recipient cells. And then in a bidirectional ABO mismatch transplant, you have a combination of both major and minor incompatibilities. So let's look at an example of this. So here we have a recipient who is ABO blood group O, and this is what's called the front type. The front type is the antigens that are expressed on the red cell surface. So because this patient is ABO blood group O, he or she does not express the A antigen or the B antigen. And then the back type is the antibodies that are expressed in the patient's plasma. So here the patient expresses anti-A antibody and anti-B antibody. These numbers are just the strength of the reaction. And here this patient is going to be receiving a donor product, which is ABO blood group A. Therefore, this donor expresses the A antigen on her red cell surface and also expresses the anti-B antibody in her back type. Here you can see that this anti-A antibody could bind to the A antigen on the donor surface and theoretically cause hemolysis because we have anti-donor antibodies present in the recipient. In this case, you can red cell deplete the donor product, and that would get rid of any offending, any cells with the offending antigen on it. That would minimize hemolysis. So this next example is a minor ABO mismatched transplant. Here, the recipient is ABO blood group A. She expresses the A antigen on her surface and the anti-B antibody in her back type. She's going to be receiving a transplant from a donor who is ABO blood group O. Therefore, that donor does not express the A or B antigen on her red cell surface and expresses the anti-A and anti-B antibodies in her back type. So here you would see that this anti-A antibody could bind to the A antigen on the recipient's red cells. Also, in this donor product, you would have B cells and plasma cells that could continue to make antigen or antibodies once they've already been infused into the donor. In solid organ transplants, this is what's known as passenger lymphocyte syndrome. In my reading for this presentation, I didn't see passenger lymphocyte syndrome noted as much, or the term used in hematopoietic stem cell transplants, but this is the entity known in solid organ transplants. So here you can plasma deplete the donor product, and that would get rid of any B cell lymphocytes, antibodies, or plasma cells. And then in a bidirectional ABO mismatched transplant, you have a combination of both, where the donor and recipients have antibodies directed against each other. For example, the recipient is ABO blood group A, therefore she has anti-B antibodies. She receives a graft from a donor who is ABO blood group B. That donor has anti-A antibodies. And in this case, you would want to both red cell and plasma deplete the product to get rid of any antibodies and cells that are expressing the offending antigen. So now let's go into some consequences of ABO mismatched transplants. The first one, as you can imagine, is immune-mediated hemolysis. And this occurs of one of two types. The first one being immediate, which would be during infusion. The second one is delayed, which occurs during engraftment about 1 to 2 weeks post-transplant. Another known consequence of ABO mismatched transplants is delayed red cell recovery, although this is not typically noted clinically until it develops into pure red cell aplasia. Pure red cell aplasia is complete agenesis of the erythroid cell line. Patients who have pure red cell aplasia are typically red cell transfusion dependent to maintain an adequate hemoglobin, and if they have a bone marrow biopsy, that will show agenesis of the erythroid line. Immune-mediated hemolysis of the immediate type is most common in bone marrow sources because these products have a higher content of red cells, and I'll show a picture of that in the next slide. Therefore, it's very important to red cell deplete the product. Peripheral blood and cord blood products usually don't require as much pre-infusion manipulation because they have decreased red cell and plasma contents. So here we have an example of a cord blood product. This is about 25 mils. This is post-plasma and red cell reduction, but you can still see that the product is much smaller as opposed to a bone marrow product, which is about a liter or more. And then this is a peripheral blood stem cell product, which is about 1 to 200 mils, depending on the type of instrument it's collected on. This picture doesn't really show it, but we all know that bone marrow products are a lot bloodier. They have a higher content of red cells. Immune-mediated hemolysis of the delayed type occurs more commonly with reduced intensity or non-myeloablative conditioning regimens, and especially in patients who receive peripheral blood stem cell products. The mechanism of action here is thought to be that reduced intensity conditioning uses post-transplant immunosuppression medications, as noted in the Worrell paper, of the antimetabolite mycophenolate mofetil, as well as a calcineurin inhibitor, while myeloablative conditioning uses the antimetabolite methotrexate plus a calcineurin inhibitor. Mycophenolate has a shorter half-life, therefore it's thought that B cells are allowed to escape and they make anti-recipient antibodies. And then the last consequence I'm going to be discussing of ABO mismatched transplants is delayed red cell engraftment, or pure red cell aplasia. This occurs mainly in major ABO mismatched transplants, particularly when the recipient is ABO blood group O and receives an A transplant as opposed to B transplant. You see increased incidences with reduced intensity conditioning if the donor and the recipient are related, and also if the recipient has high anti-A antibody titers. Here, there are recipient-derived B lymphocytes and plasma cells that make anti-A antibodies against engrafted red cells, and that suppresses the engraftment. You can treat this with steroids, rituximab, bortezomib, or plasma exchange. Usually it's self-limiting though. So in summary, so far, we know that hematopoietic stem cell transplants can come from 3 different sources: bone marrow, cord blood, and peripheral blood. Among these 3 sources, we know that there is no difference in treatment-related mortality, relapse, and disease-free survival. And also that hematopoietic stem cell transplants can occur across ABO blood group barriers. However, ABO mismatched transplants do cause hemolysis. They have delayed engraftment. You can see this passenger lymphocyte syndrome. So they have known consequences, but typically these can be managed medically. But can ABO mismatched transplants affect anything else? Kimura and colleagues in 2008 wrote this very interesting article that compared the different types of ABO mismatched transplants. I wanted to include this paper because it has a very large N. They had 5,549 patients from the Japan Marrow Donor Program who received allogeneic, unrelated donor bone marrow transplants. They noted that the 1-year overall survival was different between each group. For example, ABO matched transplants had a 63% 1-year overall survival. Compared to ABO major mismatched, their overall survival at 1 year was 56.9%. Minor mismatch was 57.1%, and bidirectional was 63.5%. And obviously the 63 and 63.5% was not significantly different, but these 2 factors were significantly different from ABO matched versus bidirectional. Another paper, Stussy and colleagues, this was published in 2002, noted small but significant differences in the incidence of GVHD between all 4 groups of ABO matched versus mismatched transplants. They also noted that minor ABO mismatched transplants had an increased incidence of minor GVHD compared to all others. They also noted that red cell engraftment was delayed in major ABO mismatched transplants, which we know. But they importantly noted that disease relapse was not influenced by ABO mismatched categories. This is an interesting slide because it shows that bidirectional ABO mismatched transplants showed significantly decreased survival. However, major and minor ABO mismatched transplants did not show decreased survival compared to ABO matched, which was exactly the opposite of what the previous paper, the Kimura paper, showed. There were a lot of very similar studies that showed similar results, that there was differences in GVHD, survival, treatment-related mortality, etc., compared to ABO matched and ABO mismatched transplants. I just had to pull a couple of representative papers for the sake of time, but there's a lot of other papers in the literature that state these known side effects. So again, in summary so far, we know that there are effects of anti-A and anti-B antibodies. Another term for these antibodies is isohemagglutinins in ABO mismatched transplants. They've been well recognized. But their significance in terms of GVHD, overall survival, treatment-related mortality, relapse, etc., is just beginning to be identified, but truly overall HLA matching trumps. So as long as a patient is HLA matched, that's the most important aspect. But the development of BAC type or isohemagglutinin status post-transplant has not been well studied. So let's look at these patients again who are receiving ABO mismatch transplants. The first patient who is receiving this major mismatch transplant, ABO blood group A, and receiving a transplant from an ABO blood group O, receiving a transplant from an A donor, you would expect that after engraftment, this recipient would express a front and back type that's identical to the donor product. So they would start to express the A antigen on their red cell surface, and they would lose that anti-A antibody and then only express the B antibody in their back type. Same with a minor mismatch. After transplant, this A recipient would, after receiving an O product, would lose the A antigen on her surface and then start to express anti-A and anti-B in her back type. Another good question is, are there any characteristics that would affect back type formation? For example, the source of stem cell product. Do back type formations differ by cord blood versus peripheral blood versus bone marrow? Also, does the type of ABO mismatch affect isohemagglutinin status or the conditioning regimen? So that's where our paper came into play. We wanted to look at the retrospective analysis to compare the rate of back type formation in terms of days post-transplant with respect to stem cell source, bone marrow, peripheral blood, cord blood, conditioning preparation method, and then also the category of ABO mismatch transplants. This was approved by the IRB. We pulled data from January 2nd, 2013 to June 18th, 2015. The EMR was reviewed for the following characteristics: gender, date of birth, diagnosis, stem cell product, conditioning preparation method, transplant date, donor and recipient ABO type, the engraftment date, which was noted in our study as ANC of greater than 500 for 3 consecutive days. Also, the recipient's front and back type reactions up to 6 months post-transplant. We used both adult and pediatric patients. So the days to back type formation post-transplant was identified by analyzing the back type reactions, which was noted in the blood bank LIS. And this is just very similar to those little tables that I showed you earlier. I'll show those again in a couple slides. But anytime a patient is going to receive a blood product, they get a front and back type screen. We retrospectively reviewed 371 patients who received an allogeneic cord blood, peripheral blood, or bone marrow stem cell transplant at the University of Minnesota. From this group, patients who underwent an ABO mismatch transplant were identified. Those who experienced graft failure, had a history of a previous transplant, received a double umbilical cord blood transplant or a donor-derived lymphocyte infusion, or did not have enough data to identify a back type at the appropriate time intervals were excluded from our final analysis. Our transplant indications were both malignant and non-malignant. We started with 371 patients. I got so excited. I thought this was going to be a very powerful study because this is a very, well, in my opinion, high N, but it got whittled down. So those who received an ABO match transplant were excluded because their front and back type remained the same post-transplant. If they had a history of a previous transplant, they were excluded as well. That was 26 patients. 6 patients experienced graft failure. 59 received a double umbilical cord blood transplant. 19 received donor-derived lymphocyte infusions. 65 patients had incomplete data. That left us with 59 patients to analyze at the end. So of those 59 patients who received ABO mismatch transplants, I then categorized them into the 3 different sources of stem cell transplants. We had 20 patients who received a bone marrow transplant, 18 received a peripheral blood transplant, and 21 received a cord blood transplant. And then I took within those groups the patients and then further subdivided them into the ABO mismatch category. In our bone marrow group, which was 20 patients, 7 were female, 8 received myeloablative conditioning, and then 8 received a major ABO incompatible transplant, 8 received a minor ABO incompatible transplant, and 2 received a bidirectional ABO incompatible transplant. In the peripheral blood group, we had 18 patients, 8 of which were female, 8 of which received myeloablative conditioning. 11 received a major ABO-incompatible transplant, 4 received a minor ABO-incompatible transplant, and 3 received a bidirectional ABO-incompatible transplant. And then finally, in our cord blood group, we had 21 patients, 5 of which were female, 15 received a myeloablative conditioning regimen, 14 received a major ABO-incompatible transplant, 4 received minor, and then 3 received bidirectional. Real briefly, I'll go into our patient and transplant characteristics. There was no significant difference in any of the groups except for in age. We did note that patients who received a bone marrow or a cord blood transplant tended to be on the younger side compared to those who received a peripheral blood transplant. Also, there was no significant difference in the ABO blood group type between all 3 sources. Before I get into any more stats, I want to talk about a few interesting patients. So there were 2 patients in the peripheral blood group and 2 in the cord blood group that expressed back types which were actually incompatible with their front types. So you would think that there would be hemolysis going on in these patients. So I wanted to analyze or to identify if that was occurring. I looked at these 4 patients and looked for LDH, hemoglobin, bilirubin, DAT, haptoglobin, and any blood smears if they were available. So let's look at these patients. In the cord blood group, and both of these patients received ABO major mismatched transplants. They both had diagnoses of AML. Patient number 1 received a non-myeloablative conditioning. Patient number 2 received myeloablative conditioning. They both were native blood group O. Patient number 1 received an A product and 2 received an AB product, and their days to engraftment are listed there. So pre-transplant, patient number 1 appropriately expressed no A or B antigen on her red cell surface and appropriately expressed the anti-A and anti-B antibody in her back type. 6 months post-transplant, she is appropriately expressing the A antigen on her red cell surface because she was transplanted with an A product. But here we see that she is also expressing the anti-A antibody in her back type. Patient number 2 is appropriately expressing no A or B antigen on her red cell surface, but is also is expressing the anti-A and anti-B antibodies in her back type. 2 to 4 months post-reaction, she is expressing the A antigen on her red cell surface. MF stands for mixed field, so that B antigen is just starting to form. However, we see that she's also expressing the anti-A and anti-B antibodies in her back type, and that remains at 6 months post-transplant. So looking into their hemolysis parameters, patient number 1 did have increased LDH and a continuously downward drifting hemoglobin. She was receiving red cell transfusions, so she had bumps that were appropriately in response to those transfusions. She had a normal bilirubin. She had negative DAT, and the haptoglobin was within normal limits. And unfortunately, she expired at approximately 6 months right after that post-transplant reaction. Patient number 2 also had downward drifting hemoglobins with bumps appropriate to red cell transfusions, but this patient had no normal bilirubin, no LDH on file, DAT was negative, haptoglobin was not on file either.
Katie, could I ask, both were still receiving transfusions?
They were. So these patients, I was able to look to see how many blood products these patients were receiving. They received between 7 and 20 units of either platelets or plasma. They were also receiving red cell transfusions as well.
But the plasma would have contained anti-A.
That's correct.
So
Yep, I will.
The source of the.
That's correct.
Okay.
Yep, I will touch on that in a second.
Sorry, thank you.
No, you're. So essentially, what we're saying is that there is the passive transfusion of anti-A and anti-B antibodies in blood products, primarily in plasma and platelets. And because these patients were receiving blood products, plasma and platelets especially, that would maybe confound their back types. So these next 2 patients in the peripheral blood group, also both major ABO mismatched transplants. Patient number 1 had a diagnosis of AML. Patient number 2 had a diagnosis of MDS. Patient number 1 received non-myeloablative conditioning, and patient number 2 was myeloablative. They both were native ABO blood group O. The first one received an A donor product, and the second one received a B donor product, and they both took about the same amount of time to engraft. Patient number 1, pre-transplant, was appropriately expressing no A or B antigen on her red cell surface, and expressed the anti-A and anti-B antibodies in her back type. 2 to 4 months post-transplant, was expressing the A antigen on her surface, but also was very strongly expressing the anti-A antibody in her back type, and that persisted at 6 months post-transplant. Patient number 2 was also appropriately expressing no A or B antigens on her red cell surface and expressing anti-A and anti-B in her back type. We'll move on to 6 months. She was appropriately expressing the B antigen on her surface because she was transplanted with a B product, but also weakly expressing the anti-B antibody in her back type. So patient number 1 also had downward trending hemoglobin levels with bumps consistent with red cell transfusions. She had a normal bilirubin, no LDH was on file, haptoglobin was not on file either. Blood smear was performed, showed no morphologic signs of hemolysis, DAT was negative. Patient number 2 also had downward trending hemoglobins with bumps consistent with transfusions. This patient did have an elevated bilirubin right around the transplant time. It peaked to 0.7 3 months post-transplant, but then it normalized and remained normal thereafter. There was no LDH on file, there was no haptoglobin on file, and the DAT was always negative. So I think it's interesting to think whether or not these patients are hemolyzing, maybe a little bit, but all of their parameters were not, it wasn't the slam dunk hemolysis that was occurring, even though the front and back types were not agreeing with each other. A couple more interesting patients. There were 2 patients in the cord blood group who expressed a front type which was not consistent with either their graft or their native type, but it was consistent, their back type was consistent with the native throughout. So let's look at these 2 patients. Patient number 1 had a diagnosis of non-Hodgkin's lymphoma, received non-myeloablative conditioning, was a native B blood type, and received an O product. Both of these patients received bidirectional ABO mismatch transplants, and patient number 1 took 12 days to engraft. Patient number 2 had a diagnosis of ALL, was transplanted with an A product, and took 31 days to engraft. Their pre-transplant reactions are the same because they're both the same blood type. They're expressing the B antigen and expressing the anti-A antibody in their back type. Moving on to 6 months post-transplant, they are still expressing this anti-A antibody in their back type, but their front type is looking as if it's typing like they were an O, ABO blood group O. They're not expressing the A or the B antigen on their surface. Therefore, these 2 patients expressed a front type which was not consistent with either their graft or their native product, but they retained their native back type throughout. And then finally, an interesting trend noted in the minor ABO mismatch transplant group. All but 2 patients who received a minor ABO mismatch transplant expressed the engrafted front type, but they retained their native back type. So this is just one example, but it's representative of all of these patients. They were, for example, native ABO blood group A, expressing the A antigen on their surface and anti-B in their back type. And then 6 months post-transplant, they were transplanted with an O product, so they are expressing no A or B antigen on their surface. And they're still expressing this anti-B antibody, which is what they should be expressing after an O product transplant, but they never developed this anti-A antibody. And this was only in minor ABO mismatch transplants. And then 6 patients in the major ABO mismatched group, 3 in the bone marrow group, 3 in the peripheral blood group. They all received major ABO incompatible transplants. They actually retained their native front and back type throughout, even after they were engrafted. So if they were native ABO blood group O, with no A or B antigen on their surface, anti-A and anti-B in their back type, fully engrafted, doing well, post-transplant at 6 months, they were still expressing the same front and back type as they were pre-transplant. So now moving on to the stats about my paper, we were only able to do a univariate analysis, but essentially there was no significant difference in the rate of back type formation comparing the different sources of stem cell products, comparing myeloablative versus reduced intensity conditioning, comparing gender, comparing non-malignant versus malignant diagnoses, and then the recipient blood group type or donor blood group type. In a different format, comparing the days to back type formation between all three different sources, we see no significant difference. There was a small but not significant difference in the days to back type formation between myeloablative versus reduced intensity conditioning. So in other words, patients who experienced myeloablative conditioning had a shorter amount of time or shorter days to back type formation compared to those who experienced reduced intensity conditioning. And then when we compared the days to back type formation by the category of ABO mismatched transplants, we saw no significant difference. Unfortunately, we had such a small N for bidirectional, so our numbers were not able to be analyzed. So in summary, there was no statistically significant difference in the rate of back type formation between the three sources of hematopoietic stem cell transplants: cord blood, peripheral blood, and bone marrow. There was also no statistically significant difference in the rate of back type formation between the transplant groups between ABO, major, minor, and bidirectional mismatched groups. And then there was no statistically significant difference in the rate of back type formation between those who received myeloablative versus non-myeloablative conditioning regimens. However, we saw some interesting trends. The first one was a trend for the engrafted back type to not form, in other words, the native back type to remain, in those who received a minor ABO mismatched transplant. We also saw that there was a trend for the native front type and the native back type to remain in patients who received an ABO mismatched transplant if they were in the peripheral blood and bone marrow group. But this last trend was not observed in cord blood transplants, and we didn't see really any trends in the bidirectional ABO mismatched transplants, probably because we just didn't have high enough Ns. Trends may exist, but we were not able to identify them. So further studies, this was brought up, there is an effect of passive transfusion of back type evolution. So as I had mentioned, patients who receive plasma and platelet products will have anti-A and anti-B in those products, and that could affect their back type expression. It would be interesting to look at the effects of RH. Also, what would the role of any previous transplants play in the development of back type formation? For example, if patients receive donor-derived lymphocyte infusions or double cord blood transplants, does that have any role in any back type formation differences? Also, it would be nice to include more bidirectional ABO mismatched transplants. We just didn't have enough here in our study. And then this is a very interesting phenomenon. I would like to investigate the development of isohemagglutinin status in cord blood transplants with respect to B cells in these products being more immature or naive than bone marrow or peripheral blood products. So we know that in babies, they do not develop a back type until about 6 months of age. So in other words, they don't have anti-A or anti-B. They develop those as they get older, and their cells or their immune system gets, I guess, more anagenically stimulated by, for example, GI flora, etc. So if a patient is receiving a cord blood transplant and has these naive B cells, you would think that those isohemagglutinins would not develop post-back type. And there was a study written by Snell, and he did show that this was the case in patients who received cord blood transplants. If they received a minor ABO mismatched transplant from a cord blood source, they did not have back type formation. We saw that in our study that there was no back type formation in minor ABO mismatched transplants. We saw it in cord blood, but we also saw it in peripheral blood and bone marrow recipients as well. So I think that would be an interesting thing to touch on as well. And then finally, acknowledge the fact that this was a retrospective analysis. We couldn't control for anything. All you can do is look at trends and try and figure out why they occurred. So I'd like to thank Dr. Cohn for her great mentorship throughout this project. Dr. McKenna also, who I don't think he's here today, but he was very wonderful at answering all my questions regarding the different stem cell products. Todd DeFore, who did my stats. References. Any questions at this time?
So I have a question about the people who retain their native type.
Mm-hmm.
Is that engraftment failure? Did you correlate
Nope.
with molecular studies of engraftment?
If they failed engraftment, they were excluded. So everyone in this study was completely engrafted by molecular.
So how do you explain that?
That's a good question. Let me go back to that. And you said it was the patients who
Like the
retained.
O's who were given an A or B product but remain blood group O,
Yeah, I think that was this one.
or like two of them each show.
Well, either way. You know, I don't know. I think that sometimes, and Claudia had mentioned this a few times, that if the immune system doesn't have to change, then it's not going to. You know, if your red cells don't have to change the antigen that they're expressing for whatever reason, or the B cells don't have to, you know, plasma cells don't have to make a different type of antibody, then it's not going to. That's not a very in-depth answer, but that was my only thought, is that if for some reason the body is able to get by without having to change these antigens, maybe that would be it. But I don't know why it would happen in certain patients and not others. I think that it's important to look at also the effects of any red cell or plasma or platelet transfusions as well.
But the antigens come with the genetics of the cell type, right? So I mean, it must be residual recipient hematopoietic tissue making blood group O cells.
Are they transfusion free by the time 6 months rolls around, so they are no longer transfusing them with type O cells?
No, so all of these patients,
See, that would confound it.
yeah.
You keep giving them type O cells, perhaps even suppressing their hematopoiesis. I mean, yeah, that would explain it. But then I don't know. You have to get them to a point where they're free of transfusion. So you quit.
Yeah, that was a big concern in our study, and you know, we really wanted to include that. Just for the sake of time, we weren't able to. In the Snell paper, they did mention the effects of passive transfusion, but that was it. They didn't correlate it with how many products patients got, and all of these patients received a wide variety of blood products. Some received, you know, a couple, others received upwards of 20 to 40 units. So it would be interesting to see if, you know, the amount of blood products and the types had any difference.
Here you're transfusing them, though, with their, in this case, a type O, native type O transplanted with an A, you're giving them O cells, probably O platelets.
I think it's usually AB.
Usually AB platelets. But if you're giving them O cells, you're giving them type O cells plus whatever
small amount of plasma in it.
Small amount of plasma goes with it. That may maintain the back type.
Yes, that's correct.
I have one more question.
Yeah.
You know, in some cases you had bilirubin or haptoglobin or lactate dehydrogenase, and others those data were available. I would have figured that there would be more of a standardized protocol for these patients where they're getting mismatch ABO bone marrow transplants, that they would, you know, it wouldn't be that there would be missing data. This would be kind of a routine thing to follow.
Yeah, I did think about that. My only thought was that if there was not hemolysis, that if they weren't showing clinical signs of hemolysis, then they wouldn't order them.
But
you
some
know.
of them had, I mean, they were kind of dropping their hemoglobin, and despite that, there still was not a consistent ordering pattern.
Yeah, there could be other reasons, though, why they were dropping their hemoglobin. One of the patients that I had mentioned, I think she had a diagnosis of AML, and then she expired right after the 6-month time period. She also had diffuse alveolar hemorrhage, you know, other reasons why her hemoglobin was dropping.
Bleeding at the same time. You know? Do you have the bidirectional one? Because that one, was a little more what one would expect, isn't it?
This one?
Let's see.
This is the bidirectional.
Yes, yes. Now, in that case, now what are you transfusing them with? O cells?
Yes. Oh, yeah. Typically, red
See,
cells.
6 months later, they still don't have any.
So-
They're all O cells circulating. They're all transfused cells. I think. I don't know.
No,
I think they're all
I agree.
O cells circulating. You never know.
Yeah, Shelley.
So in line with that, did you follow any of these a year out or 2 years out and check to see if their front or back type actually changed once they were stapling engrafted and not receiving any more transfusion?
Can you repeat that again?
Did you follow any of the front types and back types a year out from their transplant or 2 years?
No,
out?
I didn't. I stopped at 6 months. Yeah, Dr. Yohi.
So we measure engraftment studies on several different things. It can be done on peripheral blood, which is generally sorted for either neutrophil series of the T cells, or it can be done on bone marrow. For your definition of complete engraftment, what did you use? Because some of the kids who are transplanted for mucopolysaccharidosis or immune deficiencies don't get a lot of bone marrow biopsies.
Yep.
So the definition of complete engraftment in terms of what your specimen type was could also affect.
I don't know the answer off the top of my head. I'd have to check back in my original data. I can get back to you on that, though. Yeah.
Katie, I am assuming that these are automated front and back types on the...
Both manual and automated.
Okay. So how good is the automated at detecting this field?
I don't know the answer to that, but that is something, there is a lot of variation in both the manual and then automated methods. I couldn't control for that, so that's a good thought.
Pretty good. We haven't directly, when we validate machines, we do look at that, and we're getting good concordance.
Any other questions? Thank you.